right-hand corner, I think, when we go live. Oh, hang on. It looks like we're now live. Okay. And welcome, ladies and gentlemen, everybody that's watching this evening to our Facebook Live at NRAS. I'm delighted to be joined here this evening with Stefan Siebert, and you can see he's in lovely sunny Glasgow, and I hope it is sunny out there. So Stefan, thank you so much for taking some time out of what must be an incredibly busy time for all of you working in rheumatology. And but this evening's talk, we're really going to be talking about the OCTAVE study that people have heard about, which we'll touch on in a few moments, and some of the questions that people have, the sort of information that's been put out there about third doses or booster doses, all those sorts of things. So that's going to be our main topic of conversation here this evening. You will be able to put some questions into the chat. I have a colleague standing by to keep an eye on those, and we have already had lots of questions submitted. So if we don't get to your question tonight, I do apologise, but we will try and round them up so we're answering many of your questions, because some of them are very similar. So Stefan, welcome. And first of all, can you tell us, for those who might not be aware, might have heard about the OCTAVE study, but are not sure, what was it, how was it came about, and what was it hoping to achieve, and what has it achieved? So tell us a little bit about OCTAVE.
Those are good questions, Claire. So good evening from me, and thanks for inviting me again. It's great to meet you. It'd be nicer to be in the same room, but I mean, this is good enough. We'll make do. So thanks for asking me. So the OCTAVE, and I'm going to talk about OCTAVE Duo as well. So these are two linked studies and very cleverly named, as you can tell, and you'll see later on. So the OCTAVE study is really a study that was brought about by needs. We really needed to understand whether our patients who are chronically immune suppressed, it didn't matter whether they had rheumatological condition, cancer, bowel disease, we really need to understand, do these vaccines work as well in these patients? So these vaccines are great, and all the studies were done in healthy people, mainly healthcare professionals, and these vaccines work really well, far better than any of us could ever have dreamed about. So that was great, but obviously I treat people who are immune suppressed, and that's what the study was addressed to, really try and answer these questions. And there were lots of little studies going on, but really, you know, the policy doesn't roll out this drug for this person, this vaccine for this person. So the OCTAVE study included people with cancer, included people with all of these other conditions I mentioned, liver disease, kidney disease, and a big rheumatology cohorts, which we were the leads of in Glasgow. And so we're going to put all of that data together. And what we were really doing is, as people were coming for their first and second vaccine, we were writing to people, phoning people a lot of the time and saying, you're going for your vaccine, would you mind coming in and having a blood test before your first vaccine, before your second vaccine, and then 4 weeks later when it should be at its maximum? So we really wanted to see how people's immune response to these vaccines was happening in real time. And that was a crazy thing to do, because obviously, you know, our vaccines were happening in the hydro, they were happening all over the place, so they weren't happening in hospitals. So I got to spend most of February in the hydro, where I'd normally see live music, but actually this time we were doing vaccines, and it was great. It was the vaccine program really was impressive. And so that's what we've done, and that's ongoing. And I've really got a chance, and I'm only going to talk to you about the rheumatology patients, because I think that's relevant here. And there are differences between both the diseases and the drugs that people have. And I guess, what can we say? Where do we start? There's a lot of information, and I'll try and simplify it. So the good thing is that 98% of our patients responded to the vaccine. So that's an easy thing to say. It's a very difficult thing to understand, because your immune response isn't just one thing, as you'll know from your diseases. You know, that's why you all have such different diseases. There's different things going on. Our immune response is quite clever, and that's what we use for the vaccines. But actually, the thing we measured was antibodies, so the anti-spike antibody. So that's the thing that the vaccine binds to, and so you should make antibodies to that, and we measured that. Those are made by B cells, and that's one measure of the immune system. So whatever I say is only telling you about one bit of the immune system. There's a lot more going on, and we go learning as we go along in real time. So what it seems like is that 98% of our patients after 2 vaccines had antibodies that could be measured in their blood. So in other words, their immune cells had seen this vaccine and had responded to it and had made antibodies. So that's fantastic news. The not so good news is that, maybe not as any of you are surprised, that response, that antibody level was not quite as high as in the healthcare professionals. So it was a little bit lower. And interestingly, it looked like there was almost always a vaccine behind. So our patients after 2 vaccines looked a little bit like the healthy people after 1 vaccine, which is something we might come on to, so there did seem like there was a step up with each vaccine, but it wasn't quite as high as we'd seen in healthy people.
Wow. So that beautifully put into lay language there, I'll say, and it's very, very complex science, and it's brilliant to be able to understand that there was, and I mean, we're talking how many people participating in this study? I mean, it wasn't just a handful. This was large numbers, which would give us that sort of data. So just to go back, you said you saw, was it over 90% response in rheumatology patients? So that will include people with other conditions, not just RA. Is that correct?
Yeah. So now that's a good, can I step in there, Claire? Because that is complex. So this was happening so quickly, we couldn't do all of these bloods, because there's no way we're going to say to someone, hold on with your vaccine, we want to do some blood tests. And everyone, the priority was for everyone to get their vaccine. So we had a group where we did everything. And some of these tests were they had to be, our lab people were in the lab till 10 o'clock at night. The bloods were being sent to Oxford, that we did everything. So we've done the whole immune system, and we haven't analyzed all of that yet. Those people where the first 160 were people with rheumatoid arthritis or psoriatic arthritis who are on either a TNF blocking drug and or methotrexate. So those people, and there was a small group of people with vasculitis who were on rituximab.
Wow.
Then we've got a big group of another 700 people where we couldn't catch them in time. And this was never the intention to catch them in time. We didn't have the money let at the time, but they've all kindly come back after their vaccines at their maximum peak, four weeks after it, to come and give us a blood sample. So those are people with all drugs and rheumatoid arthritis, whatever biologic you want. It had to be biologics or methotrexate, and people with ankylosing spondylitis and other types of arthritis, really in that bigger group. But the detailed information we've got at the moment is rheumatoid arthritis people on TNF drugs or on methotrexate. They could be on other drugs as well. And also people on rituximab who happen to be vasculitis patients, but I think the same principle we're seeing come out in the bigger group.
That's phenomenal that so many then came, after their vaccines to participate. And I think that's a credit to everybody involved in the study, because that's hard, recruiting that many people. But it just shows the interest that people have and how they want to contribute to this amount of data. And I would just say to everybody watching this evening, if you're asked to participate in some small way to providing your data, even if it's through something that's going on locally, never mind a national study like this, please do, because it's that data that will give us the answers in the long run. So how then will those people now participate in the OCTAVE duo, or do you anticipate there will be quite a fall off, or do you expect to recruit more people to the OCTAVE duo study?
So can I pick up on the first point you made, Claire, and just thank everyone. If there's anyone who participated and who offered, thank you so much. And because we were doing so many different, Birmingham was doing mainly people with cancer, people with kidney disease in London, the sites couldn't actually take more people. And we had so many kind offers of people willing to give us their blood. And so thank you for that. And as Claire says, there will be, you can immediately think of the next questions. How long does immune response last? How long, so there'll be lots and lots of questions. So please do keep contributing, because we all want to learn as quickly as we can so we can reassure our patients and we can make the right decisions. So I mean, your immediate question, as I've said, is most people responded, but not quite as well. So that's a problem. And the question is what we do there. And because we saw this jump from the first one to the second one, I think if there'd been no jump, you would have thought, are these vaccines safe? Are they not safe, effective? Are they going to work? But so the feeling really is that our patients probably need an extra dose to get above the same hurdle. So the safety level, who knows? No one knows quite what is enough, but we do know that our antibodies drop over time. So, we're seeing that. And so we wanted to get our patients even higher so that they are more protected. And that's why the feeling is that we should do a third boost, a third dose of the vaccine. And that's what OCTAVE Duo has done. So a lot of our patients, so the nice thing about this study is we were able to give our own participants their results, but also we were able to say to the ones who didn't respond, who had a very low response, saying, look, your response is low. Would you like to come into OCTAVE Duo where we can give you another vaccine? And what we did this time is we actually gave people either the Moderna or the Pfizer vaccine, because there's a bit of evidence that mixing and matching might be better, but we've randomized them. So there's no placebo, they got a third active vaccine. And we're just looking at some of those results, and they haven't been run, but smaller other studies are saying that actually this looks like a good strategy for the people who've had a medium one to jump a bit higher. And I can see there's a question there about whether OCTAVE Duo is recruiting. And the answer is not for the rheumatology group. It is for the cancer and the other groups. You can't believe, usually cancer is the big drug and the research, everything is cancer. Rheumatology and kidney disease have been at the front of this so much. It shows how involved our patients have been. We have finished recruiting, so everyone's had their third dose of the 100. We've done another 160 people who were low from the big 700 group. They've all come in. Most of them have come in for bloods already, so we're just starting to look at those. The other cancer groups are still waiting. They still need a lot of patients, and so if anyone knows people and you hear about OCTAVE with the other conditions, but rheumatology, kidney disease, dialysis have finished recruiting. So well done, all of you. And
that's amazing.
Yeah, as I say, we were able to really take the people from OCTAVE who didn't have a good response and actually do something, and which is really delightful for me as a doctor, being able to not just tell people this and then action that as well. So we should be getting that result. And obviously, some of the people from OCTAVE, the initial study, are coming back for their 6-month blood test. So we're also learning not only how high did you get when it was maximum, what's it doing 6 months later? So all of these things are helping in parallel. We can't wait, can we? COVID's here. We just need to act and give evidence so that we can make good decisions in clinic for our patients.
Great. And I know there's a huge amount of data to analyze and put into some report, but roughly what sort of timelines are you talking about before you might have some of the findings from the OCTAVE Duo?
So this is where research is quite unusual for us. So we always have research and we lock the data and we spend ages analyzing it. That's not happening here. And it's very uncomfortable for our statisticians because we don't like giving results out unless we're certain. But actually with COVID, you can't wait. And so there's sort of a bit of two things happening in parallel. That data will take a bit longer till it's published, Claire. But actually the initial data is feeding to the vaccine task force in real time. So they're seeing some of this data already so that they know it's preliminary, they know it's going to change, but actually so they can make decisions. Is it worth giving a third dose? Do we need to do something else? So just to reassure people that even when you don't see data, out in the public, things are happening behind the scenes. It's so unusual because we do things in research and 10 years time, something might change in clinic. That's my usual research. Now things are happening before we've even published them. So just to, sometimes it may seem to you like decisions are being made without evidence, but actually there's a lot of evidence. It's coming from COV boost. There's other studies going on. Ours happens to be focusing on immune suppressed people because that's what we care about. But there's data coming from everywhere, and it's not always out in the public domain. So the initial stuff's already going to the vaccine task force, Claire. So they're already seeing that now, which is right. It actually OCTAVE has fed into their decision with doing this third dose. So they've already taken that and they've mentioned that in their documents, and they are seeing this data. And obviously they're seeing data from Public Health England and elsewhere as well. So I think the full OCTAVE publication will be the next few weeks. I think the Duo will be longer. And it's a tricky one because how long do we wait for every patient from cancer and from the other groups to come in? I want to know, my rheumatology colleagues want to know, my patients want to know the status. So we're having, constant discussions. How much is good enough? What is good enough data to tell people?
And just a question that's just hopped into my head as I've been listening to you is, of course, we're getting into flu season now. And of course, we definitely encourage everybody with RA to have a flu vaccine. So will that be factored into some of those 6-month results that you're going to be getting to ask whether they've had their flu vaccine, or and also the OCTAVE Duo? Will that be recording those that have had the flu vaccine as well as their third dose or whatever?
No, those are great questions, Claire. So there's so many questions we're trying to answer at the same time. And what's quite frightening about this is people didn't ever do this vaccine research in our patients, because actually with flu vaccine, it's been the same question every year, but no one's answered. What's the best way to give flu vaccine? What should you do with your methotrexate? But no one's done it. But now with COVID, we're having to answer all of these questions. So our 6-month visits are people coming in just before their next dose, Claire, because we really want to say, how low has it gone without another boost? And then they will be coming back later on to see what has it done afterwards as well. And this study, as I say, we're having to change it as we go along, because the vaccine task force changes what's happening. We weren't planning to, we're rushing the 6-month visits now so that people can have their blood test before there's their vaccine from the NHS. So we won't be capturing that this time, Claire. And it hasn't been, the OCTAVE Duo participants just got their COVID vaccine, and they'll still be going for their flu vaccine. And as Claire said, go for that. Yes. The flu is still serious disease, and having the two together seems to be particularly bad. And so go for that. And that's the plan at the moment. You get both together.
Yeah, sorry. You mean getting both COVID and the flu would be very, very bad, but getting both your flu vaccine and your COVID vaccine is very, very good. Just wanted to clarify that.
Thanks for putting what I said into English, Claire.
So we have got, we've had lots of questions submitted beforehand. Some of them are very similar. So I'm going to try and group them as best I can. And I will say to anybody watching, we can't answer your individual, you're on X milligrams of this and something, what is it for you? I'm afraid, because that's too individualized, and we wouldn't have your full data. So these are more general questions, and a lot of them are one around the should I or shouldn't I miss a dose of my whatever it be, methotrexate, be it a biologic, before I have my next dose, my third dose.
Yeah. So do you mind if I pick up on the third dose, Claire? Because that's a trick. I think that's very complex, and I think it's really, I find it hard, and certainly my colleagues do as well when I've spoken to them. So hopefully you've all had 2 vaccines. If you haven't, go for it. It's not too late. Just go for the 2 vaccines is what I would say. And I mean, the evidence looks like the effect starts 2 weeks after the first one. It's not as what I've told you and what the vaccine task force has seen. It's not as good in our patients. The other thing that's happening in parallel is our antibodies drop over time anyway. So a lot of the healthcare professionals like myself, we were vaccinated back in February, January, February. So we're already 9 months down. So at the moment, what's being rolled out is the third dose, but it's 2 different names. There are 2 different things going on. There is a booster dose, and there's a third top-up dose. So the booster dose is what I will get. Hopefully I had a good response. I don't know. I haven't seen my antibodies. I've had a good response, and over time that's worn off. So that's a time decision. And they've decided to do that now because of winter coming, flu. So they've decided a lot of people, and elderly people who were vaccinated very early, healthcare homes, have had their one. They need another booster. So they have good response and they need a boost. Mm-hmm. What I've said to you and what OCTAVE has shown is that our patients never quite got to that same level. So what they're proposing to do is they're calling it a third primary. So first primary, second primary, third primary. So it's part of your first course to top you up to the same level that hopefully everyone else got to. And then the plan is, or the anticipation is, that over time that will wear off down as well. And you will need a boost again. But the trick with these ones is to get you to the same place. If we had known everything we know now, we would have done that in July. We didn't know it then. So these 2 are happening at the same time. But I guess, and for most of you that won't make a difference, the message is, if you get called for your third one, go for your third one. So if you're a healthcare professional, you had it 9 months ago, 6, 7 months ago, go for it. But if you're immune suppressed, and that's most of our patients, you will get one to come in for your top up. And the anticipation is you will get a booster again. So this isn't your booster and then off you go, you're going to be left alone. People will watch that, that's safe, but this is being counted as your initial course that you are just finishing now. You needed 3, I needed 2.
Yeah.
We didn't know that before and we know that now, but you need, looks like you need 3.
So is there a difference between the actual amount of vaccine that you're getting, for want of a better word? Is the dosage the same for the 3rd primary as it would be for a booster?
Yeah, that's all the same. So each individual one is the same at this stage. There's some talk about people are testing COV boost. Some of the studies are testing lower doses. Maybe you don't need as much in future, next year or the year after, who knows? But so obviously we all like using the least of anything we need. But at the moment, they're all the same. And as I say, we couldn't do the 3 together because we didn't know that it was needed. We know now, so people are almost catching you up again. But be reassured, it doesn't mean you're going to be left out there then. If you don't need a boost in future, it means that the data is showing you don't need one. It's protected enough. And the other thing that's just worth saying, antibodies aren't everything. I said at the beginning, there are other cells that are involved here. And what surprised me and delighted me is that even in our patients where they really weren't getting many antibodies, the T cells and some of the other responses look to be really good. And so remember, it's like memory. You don't, your own memory, you don't need to have the thoughts at the front of your mind. You just need a little bit at the back, and your vaccine memory is a bit the same as well. You don't need, it's right, you don't need this high number all the time. You need it, and then you need the memory, and you want to keep the memory. You want to be reminded of it, but you can't just think about that, because you've got other things to think about. And that's how the immune memory as well. It needs a little bit that really knows this virus. Every time it sees this virus, says, I know you, I'm going to get you. But it doesn't want your immune system just doing that. It's got other things to do. So don't be too caught up in antibodies. The antibodies are useful for me. They're useful for telling us what to do. They're useful for telling us people we need to be careful about and worried about and take other plans. But for you as an individual, they're not the be all and the end all. But there's good reason why a 3rd boost. And again, the immediate question people say is, well, there's quite a gap between the 2nd and 3rd. That's probably a good thing. If you read a book and you read it the next day, I've forgotten it. I mean, most of you might be all right, but I've forgotten it. But if I read it now and I read it in a week's time and I read it in a month's time, I'll remember much more than if I had 3 very quick days together. And our immune memory is the same as well. So having gaps is actually, because your immune system says, I saw you. Wait a minute, it's you again. It's you again. I'd better remember you. So that spacing, don't worry. Everyone worries this gap is a problem. It's not. It's good for memory. Obviously, we want you to be protected now, but it's good for the immune memory. So don't worry about that. It might turn out really well as it is, and it's looking that way.
That makes great sense. And somebody's just posted a question about when we talk about low response, what is low? And I don't personally feel that doing home antibody tests is at all helpful, but that's my personal opinion, because there are so many out there, but people are paying for these antibody tests to give them some sort of a reassurance if they're safe to do something. But then again, it's interpreting those, what is a low response and what isn't. And that's very difficult. I think even within primary care and people aren't experts in understanding these test results.
And the tests aren't all the same, Claire. So our OCTAVE ones were done in Public Health England. So they were the gold standard. But even they haven't done enough tests to know what is enough. They know when there's no results. They've got a cutoff saying you have got no antibody. That's bad, or not good. We know that. But then there's a big range. And as I say, the range goes up to about 200,000. What we're seeing is most of the healthcare professionals, they're younger, they're healthy otherwise. They tend to be in the tens of thousands. Most of our patients are in the low thousands. So that's still good, but you can see that's lower. But what's coming out at the moment is that it looks like below 400 is not enough. You're starting to run a risk of getting more severe COVID infection again. And actually, that was our cutoff for OCTAVE Duo as well. So everything's sort of coming around at 400, but 401 test isn't the same as 400 in another test. And so I think it's limited value. I think it's useful. So one of the things we're doing is our health board has just started doing these antibody tests for people who come in with an infection. So you've got a COVID infection, you've you might have cancer, you might be on chemotherapy, you might be on one of these drugs, and you've been vaccinated, and they want to know, have you got any antibodies? Because if you have, then that's great. They know we know it's going to be milder. Remember, the vaccines don't stop you getting the infection. They stop you getting severe infection. They stop you getting to hospital. But so you're now in hospital, you've had the vaccines, and they do the antibodies. And if you've got no antibodies, they are already making other plans. They're saying, look, these people need extra help. These people need something different. So for example, you might need these monoclonal antibodies, which our friend Trump got, with a mild cough, but the rest of us don't need and don't want. So people are using the antibodies to start saying, this is the group of people we need to be really careful about. Look, as soon as they get sick, give them something extra, give them an antiviral, give them, whether we tocilizumab earlier, whereas these people, they're probably going to be fine. Let's keep an eye on them. But actually, so it's useful in a hospital setting. I think it's limited outside. We all like to know our own, but even if I haven't tested myself, because even if I knew mine was 10,000, I wouldn't act any different than if I knew mine was 100, 200. I'd probably make a difference if I knew it was 0. But actually, that other step, if let's say I was 1,000 or 10,000, it just doesn't tell you anything useful, and it's one bit of your immune system. So I understand why people want them, but I think it can be false in either way.
Yeah, I think it can give you false security or false anxieties. So I absolutely agree. And I think the key thing to remember, just to pick up on and to reiterate what you just said there a moment ago, the vaccines will not stop you getting COVID. They will just reduce your risk of getting seriously ill and ending up in hospital, etc. There's lots of people that have been double vaccinated and got COVID. And a question that just popped up there, does that count as the third dose? No. And no, that definitely doesn't. So please, just continue to be vigilant. I know lots of people are quite relaxed now about wearing masks, and perhaps, the social distancing isn't great anymore. And of course, now as we head into winter time, people are coming closer together and staying at home more. But, it's still very important to keep the ventilation, wear your masks. We're very keen for people to continue wearing masks. I know it's not legislated, but it still might be the wise thing to do.
So Claire, people who have had infection do get a better boost with their vaccine, but there's some evidence that infection doesn't last as long. So the memory isn't as long lasting as vaccine. So if you have had COVID, have a gap before your vaccine. You shouldn't have it too soon, at least a month, but possibly a bit longer, but then still have the vaccine, because actually you're getting the added bonus that it's likely to last longer. So you've had the horrible bit, you might as well get the good bit as well. So my recommendation, don't have it too soon, because that's too soon. You're not right. You should wait at least a month, maybe 2 to 3 months, and then have the boost, because the vaccine, because it'll just much more likely to last longer and get the better benefit, the better, absolutely. The better it is overall. You were asking a question about the medication.
So I was asking you, there's lots of people saying, getting slightly mixed messages about whether to miss a dose of whatever medication they're on before they have their third dose or booster. Yeah. And again, I know there are mixed messages out there. So just your opinion about that.
So I think it is so the answer is we don't know, is the honest answer, because as I said, we never really had to do this for flu, because, flu came around every year. There's some evidence that stopping methotrexate before a flu vaccine might be useful, but that is it. That is pretty much all the evidence. The JCVI letter going around at the moment has got mixed message about stopping. And I, as a clinician, I'm not entirely in agreement with that. Because in our patients who've got chronic diseases, you're not taking your drugs because you don't need them. You're taking your drugs because you need them. The worst thing you can do is have a flare-up. The worst thing you can do is to come off your medication. If you're having a flare-up, I think the chance, we don't know, but the vaccine may not work as well. So the best thing you can do is be stable. Obviously, if you can, your timing might work out if you're on a monthly drug or a 2-monthly drug. But my recommendation for my own patients isn't to miss. I know some clinicians say miss a week beforehand of methotrexate. Methotrexate's got quite a long half-life. To me, it seems like it's still around anyway. It may help, but it really, I think it's dangerous to say that for everyone. And speak to your consultant. If you've been really stable and you may want to do that. But actually, because you're getting a third dose, if you weren't going to get a third dose, I'd say, maybe we would have done that the first two, but because you're going to get that top up to get you to that level, yes, your drug might have kept you a bit lower, but you're going to get the third one now. So hopefully that's going to push you up there. So particularly for the third one, it doesn't feel great. I think the one drug that's different, two drugs, the one is steroids. Obviously steroids, short life. We want to try and avoid those. We do think steroids have an effect. We've captured when everyone had a steroid injection, steroid tablets before OCTAVE vaccines, but we haven't looked at that yet. It's just, we've got that for everyone. And the other drug, that usually if you could avoid steroids for 2 weeks before the vaccine is the advice. Obviously, if you're on regular steroids, do not stop them. I'm talking now a steroid boost if you need something like that, a Kenalog injection or something like that, steroid injection. But ideally, but it's not always possible. And I think you should still have the vaccine, rather than not having it. But it's reasonably easy to rebook. So steroids, if you can, don't stop them if you're on them long term. That is not, again, the booster, the top up will get you there. Then the other drug is rituximab, because rituximab does affect B cells. So these are the cells that make antibodies. And so if your only measurement is antibodies, the rituximab patients, I've said that 98% response. A lot of the rituximab patients we've had in the last year did not get a good response or did not have much response at all. And that drug, it's because we're just measuring B cells. Again, their T cell response, their other immune response seems to be good. What that means for infection is a longer term question, because now we're capturing, did these people end up in hospital with infection, yes or no? Because that's, at the end of the day, it doesn't matter. The bloods are just giving us clues early on. What matters is, do people stay out of hospital? Do people stay well when they get COVID, And so we will capture that, but that takes time and we don't want to wait. We're too impatient. But rituximab is the one you really want to have a discussion with your rheumatologist about. When should I have my rituximab infusion? And again, it's an easier drug because it's 6 monthly for most people, 9 monthly. So often waiting 2 weeks afterwards isn't such a big deal,
Detrimental. No.
But have a discussion. I think rituximab is the one you really want to speak to your rheumatology team about, saying, this is when my vaccine is. What should I do with my rituximab? I think is the one where you want to try and get the best chance there.
And you mentioned about the people on the OCTAVE study, most of them being on either an anti-TNF, but people are asking, well, what about people that are on, say, the JAK inhibitors? Are they better protected? Do they have a better response? Or I think the question that somebody's put is, are they better protected against COVID? Well, there's no guarantee that any of these medications that you're on will protect you from COVID. But, were there any in the OCTAVE study that were on anything else besides an anti-TNF on the end?
No, so Claire, that bigger group that we haven't analyzed because they came in later. They is people on everything, IL-17, psoriasis, tocilizumab, abatacept, that's all in there. We don't do things totally by random. We deliberately chose rituximab, TNF, and methotrexate because those were the drugs we were most worried about. The rituximab and antibodies are looking what I expected, B cells not making antibodies. What I would say is that it's a handful of people on a methotrexate TNF who did not make any antibodies. It really was very, very, very rare. It was the rituximab group driving that side more, the rituximab vasculitis. So they're a bit different. They get more steroids than people with rheumatoid, so there's other noise going on. But very few people, and we will capture the other data, but I don't believe, and I've got no evidence, it will be any less than for the TNF and methotrexate. So I think we deliberately chose the big culprits and put steroids in there as well, because those were the ones we were worried that they wouldn't give as good a response. Yeah. The other bit of the story is once you get COVID infection, yes, as you know, there's a bit of a story that maybe our patients don't get as much inflammatory response. So there's still two problems with COVID. One, the virus, and some people are unlucky and the virus is too much and you get too much, or you've got lung disease and the virus, causes the problems there. And then people get better and then they have that second worsening, which is the immune system. And it looks like maybe our patients aren't getting as much of that second because their immune system, sort of the rebound is too much and it's your own immune system overshooting. Maybe our patients aren't getting that much, but there's still the bits in the front. And as Claire said, if you can avoid it, you don't get it. That's my approach to this, But we're trying to do everything with vaccines, with everything else, that if you do get it, because there's a lot of it about, how can we make sure our patients, stay as well as possible and don't have need hospital and all the bad things that we don't want happening.
Exactly. And I think there's also a key message out there. We were just talking before we went on air about the question about children getting vaccinated, and if you're somebody who lives with somebody with an immune compromised or immune suppressed condition, the importance of those people getting vaccinated as well, to keep those that are around them that are more vulnerable as safe as possible.
Yeah, that's where it's, we try and tackle both sides, don't we? Try and not get COVID, which is the masks, the social distancing, all the common sense things we're doing. And that includes other people around you being vaccinated. So maybe my vaccine response isn't quite as good because I'm immune suppressed. What can I do? And the bit is have the people around you protected as well. So build that shield, because as you've all seen, I mean, the shielding itself is coming to an end, and that was never sustainable, and it wasn't good for some people. But that's there are some people who need more of a shield and more protection by having them people around them vaccinated. And again, that applies for the whole general population. The more people that get vaccinated out there, the better for all of us is my feeling, and we all win, for every single person who gets vaccinated. It's another win for all of us. And as I say, I can't stress how much these vaccines work. I mean, if you told me a year ago we were going to get these, I would never. It's even great that we're talking about how good, rather than how, So I think we should still put things in perspective. I totally hear, I speak to people all the time. I hear people's fears, but there's lots of other good things happening. It's not just. And again, just to reiterate what I said earlier, the hospitals, and I certainly know my hospital, I'm involved in those, the rheumatologist doing acute medicine is scary, shouldn't be allowed near sick patients, but we involved in the decision saying, look, what happens with people with no antibodies come in? What happens with someone who's just had rituximab and we don't think they've got antibodies coming in? With someone with chemotherapy, someone with this, coming in. So people are making plans for how do we treat these people, and so it's not a vaccine or nothing. It's a big package, and even though it doesn't always feel like people are thinking about you and caring about you, there are a lot of things pushing in the right direction, and obviously some things pushing in the wrong direction, but most of it's going in the right direction. And I think there's cause for optimism, but also cause for common sense and being safe.
Absolutely. And I've said this before, and forgive me for reiterating it for those of you who've been on many of these Facebook Lives. The rollout of the vaccine will be written down in the history books as one of the most amazing medical achievements since probably the penicillin was discovered. It is phenomenal, and it's huge credit to the scientific community and the healthcare professionals at the coal face, so to speak, for delivering it. It's such pace. It's just phenomenal. So, it is hats off to everybody involved. There's some various questions that we had put in. I think we've answered some of them as we've been talking around here, but I will just read through some of them in case we missed any. Somebody saying, interested in the stats if only on methotrexate. They have a teenage son who was single vaccinated but tested positive recently, but everyone else in the house tested negative who were fully vaccinated. Well, that kind of answers itself there, really, doesn't it? That the fully vaccinated had more protection. But yeah, I'm assuming that person is on methotrexate only themselves.
Yeah, so if we again, what you're feeling is there's degrees of immune suppression here. There's obviously, some of the cancer immune suppressions are very high. The stem cell transplants, lymphomas, that's a different level again. And I think in our field, there's sort of rituximab, steroids, then the biologics and methotrexate. And fortunately, we don't think drugs like sulfasalazine alone or hydroxychloroquine alone have any negative impact on the vaccine. So I think you can consider yourself not immune suppressed in terms of your vaccine response. And so I think there's, we Claire and I were talking about methotrexate dose. I think methotrexate in general should be considered. It's so individual how people respond. You'll all know that. Some of you feel.
And the dosage, it's very variable from.
But I think methotrexate, you don't worry about what dose you're on. You should just consider that you need the additional dose. You need the top up. That's the way I'm thinking of methotrexate for my patients. Although we all know how individual these drugs are. They work for some people, they don't for someone else. And we just don't know that. So we just do the safe thing. We just assume that everyone needs a top up.
And I think you've kind of touched on this already. Somebody is asking about, do you foresee that, even after you've got your third dose and, that probably boosters will become commonplace sort of every 6 months or certainly going into the winter months in the future?
I don't know is the honest answer, because antibodies drop over time. That's for sure. But I've already said to you, you don't need this high antibody level forever. You wouldn't want it forever. We want it now. We want it this winter. But actually, we don't want it forever. And we will start getting a data, and that won't be blood test. That'll be what happens to people who've had 2 or booster vaccines. Are they getting more infections? Are they going to hospital? And if the answer is no, we may not need that. We may need it very rarely. So I don't think we do. My anticipation is that you all need the third top up. Our data's shown that the people are immune suppressed. I think you probably will need and deserve the booster in 6 to 9 months, because that's what everyone else looks like they need. So you probably should, you're still catching up. Your 4th one will be like everyone else's 3rd one. But after that, I think we have to wait and see. I'm going to be optimistic here and say that, we might need one, but it'll be an extra thing. A good example is hepatitis. Sometimes you need 3 or 4 vaccines often for hepatitis B. And then you're immune for 10, 15 years. So it's not always like the flu. The flu is quite an unusual virus that changes a lot every year. So for hepatitis, 1, 2, and 2 don't do a lot. 3 seems to do suddenly a big kick in some people need 4, because we all get tested before we were allowed to work in the hospital. But then your immunity lasts 10, 15, 20 years. So I think let's wait and see. The jury's out there. I think we're ready if we need to do more, but I wouldn't be surprised if we don't. So let's just get everyone to the right level, and
yes,
that's
exactly.
the trick.
Just a question that's just popped up here, it just because we were talking about rituximab a moment ago, and somebody's saying, so should they, the letter to say that you don't no longer need to shield, are they saying, asking should they keep isolating themselves? And my personal view, again, is it's very individual. I mean, we know that not going out, not seeing people, not mixing can have other impacts onto somebody's health. And I think, if you're still nervous about, because you're on rituximab and you feel more at risk, don't go into a big crowded, concert perhaps, but do go for a meal out with friends. It's controlling the environment you're going into. Would you have anything else to add to that, Stefan?
I think it's a valid consideration. And remember, even rituximab in cancer, it's used sort of every month. And so you're getting a totally different level of rituximab. I think that is the group where the antibody response was the lowest. Delighted to see that their T cells are still getting a message somehow. So what that means, don't know yet, but their antibodies were the lowest. And I think we need to be careful with rituximab. I think that is a group that we certainly as rheumatologists are more concerned about and keeping a closer eye on. And as I say, what we're doing is telling our medical colleagues, look, if any of my patients with rituximab come in, let me know and take care, be extra careful. But I think, and then there's how long ago you had your rituximab. It's a very long acting drug. I think if you had it more than a year ago, that's, that's probably not a big consideration. But if you're still on it and you're having it, I think it's realistic to be careful. But as Claire says, I mean, the reason you're getting your rituximab is for quality of life and to do things. And if you can't, so there's a real balance. And it's going to be different for everyone, because people have got other conditions. I've got other family members who are sick and different types of work. So I think it's really trickier. I think the rituximab one is where there's the most, nuance and things. The other drugs, I'm more reassured. The 2 wasn't as good as everyone else's 2, but I think the 3 is going to be as good as 2. So that's right. For me is a positive feeling that we're getting there. We just wish we'd known that earlier, because we could have done that. But I think the rituximab and certain other, certainly some drugs in other conditions and cancer. And so I think it's, again, be careful. The shielding one's tricky. That's a political decision as much as anything else. But I mean, have a discussion with your rheumatologist and the rheumatology teams, especially about rituximab. I think, it's be careful, but also, do
Live,
things as Claire
live your
says. Yeah,
life.
yeah.
Yeah,
I think you have
exactly.
to.
And I think there's some concerns about, if they are well controlled on their medications, or that they may flare after having a vaccine. And it's kind of tricky, because certainly even healthy people, once they've had the vaccine, have felt a bit fluey, maybe for a day or two, quite achy joints. And so not necessarily, but, how did that come out at all in the OCTAVE study, that people did experience any sort of flare symptoms?
No, so again, the people have done big data. So I can think of dozens of my patients following a flu vaccine who definitely feel they've got a flare. But actually, on a big group level, the data always says that most people don't flare. So again, the question is, was it coincidence? But I know some people have been stable for a long time flare. So there's, again, individual stuff. But on a group level, it doesn't seem to. And for the COVID vaccines, I haven't seen any data that there's flares. In fact, I've seen some data that they aren't. And this is in the realm of anecdotal now. So because we saw 160 people 4 times very quickly, and after each vaccine, we chatted to them, we did their bloods and everything. We even collected their saliva for antibodies. But what struck me with all of them is how few of them actually had pains, and how few of them had a flare-up. And what struck me, anecdotal, is fatigue was much more of an issue post-vaccine than I think, than people who, and I think it's because you've already got that as part of your disease. But actually, they didn't have as much pain. And I don't know if that's because they were immune suppressed or because they just used to pain. I think there's a bit of that, whereas most of the rest of us are softies, and a bit of pain we all feel. But actually, we didn't see many flares, and that's coming out that actually there aren't many flare-ups, and all the more reason, stopping your meds and having a flare-up just seems like a big price to pay. But it's an individual decision. But no, I don't think that's a reason not to have your vaccine, and we can manage that. But it really, for 99% of people, that doesn't look like a consideration, fortunately,
Yeah. And there's I suppose for some of the younger people that were in that last cohort, if you like, of people with immunosuppressed conditions, but were in the latter end, rather than the people that were vaccinated right at the very beginning. Do you feel that there's an optimum time between that second vaccine and this third primary? Is it 6 weeks? Is it 8 weeks? Is it 2 months? Or does it really matter as long as you get it?
Well, I think for everyone it's going to be at least 2 months, but just you shouldn't have it within 6 to 8 weeks. That's too soon. After that, you just haven't got a chance for memory. But you're right, for a lot of the older people and people who've got other conditions, for them, the boost and the top up are happening at the same time. But actually for the younger people, you further down the queue, and that queue is quite muddied at the moment from where I'm sitting. And I suspect for you as well. My feeling is they are really trying to get the people who are high risk for flu vaccine and all that out the way quickly, get that done in the beginning. And there is absolutely an intention to get everyone who's immune suppressed. As I said, all the drugs, maybe not hydroxychloroquine and sulfasalazine on their own, but all the other rheumatology drugs. And I think that'll come to you, and I think you should have it. As I say, it's likely to be closer to December than to be, now. I don't think that matters. I think, but you should have it. Number one, you still need that top up to get to that same level. But I don't think the timing is crucial, Claire. I think it's just to get you there and I do think that you may need to do a bit of work, because at the moment that is quite challenging. And in Scotland, the process is becoming clearer. People are getting their letters, but they are trying to start with the priority groups again. The good thing about our younger immune suppressed patients is, back to that discussion, if they're unlucky enough to get COVID, they tend to do better. So let's get the people who, if they get COVID, tend to do worse, and that is the elder people with other comorbidities and immune suppressed. So top them up and get to them sooner than everyone else. So,
and I know, people have asked, well, who's going to contact me? Who is it going to be? My GP? Is it going to be my rheumatology department? And the thing is, it will vary between the different nations of the UK, but also perhaps in regions, as to how that booster program or that third dose primary program is being rolled out. But what I would urge you to say is, don't all jump on the phone to your rheumatology department, because you will be contacted. And I think the clear message from the British Society for Rheumatology is that everybody within for the RA population will be approached for a third primary dose. Very, very few people might be exempt or may not, but if you're offered, please do take that third primary dose. I think that's the key message. I think it's only for people that might be on just hydroxychloroquine or just sulfasalazine, but at the same time, very, very rare. But even then, why wouldn't you? If I'm offered a booster, I'll be definitely going for it, and I will be definitely going for my flu vaccine as well. And thank God I don't have any conditions, but I think the more we can take up these wonderful offers, the best.
Yeah. So just to be clear, so the third is when you called for it, and then if you need a booster, fourth one, that should be a minimum of 6 months. Because that is then when it's wearing off. That's a time-dependent one. And so just to be clear, don't expect another one just because other people are catching up still. Yes. Your booster just gets pushed a bit further. You may not need one. And if you don't get one, it means the data says you don't need one, which is also good.
Yes. And, and again, when I said don't hop on the phone to your rheumatology units, don't also pester your GPs. They are doing their very best and they will get to you. It is that prioritizing those that are going to be at much, much higher risk of being seriously ill or hospitalized. Let me see what else. There's other questions about antibodies, but I think we already answered that. Comorbidities. Were there many people within the OCTAVE study that had more than one immunocompromised condition, and what were some of the results for that?
Yeah. So that's probably the bits of the analysis that's giving the statisticians nightmares, Claire, because you've got all these different diseases that we're looking at. We're trying to compare those. But you're right, people aren't one disease, are they? We've all lived with lots of things. And so we've captured that, and then the noise and or diabetes, all the other things. And you're quite right, some of our patients have got cancer as well. So we haven't started looking at that. And I think that will be a later thing because it's quite tricky. But I think that the impact of that on the vaccine response won't be the big deal. It'll be, well, it might tell us that actually, for example, the reason that's useful is, let's say I've said 400 is enough for most people, but that might not be enough to people who've got other diseases. They might need 600, 1,000, So the comorbidities might highlight people who are still at higher, they need even more to be protected, So I think it's for the subtlety in there. I don't think it'll change things up front. To me, I think in our patients, it is their disease, but the drugs they're on, that is the question, that is the big question. If you've had a stem cell transplant, that's completely different because your whole immune system has been changed. So there's slightly different questions why people are immune suppressed and transplants as well. So in our patients, I think it is the drugs. And as I say, that's why we put those ones up front. And I think the other stuff is subtlety, but it's detail, but it's not going to change. But we've captured all of that, that it's not about vaccine response. It's about, despite the vaccine response, are you as protected,
Yeah. And it is, and I just before we close, I realize we've gone terribly over time, but it's fascinating. Sorry. And you've done such a marvelous job at cutting through the noise. And that's what we're trying to do here at NRAS, is try and bring you the information you need in accessible terms. And I hope that you found that helpful this evening. And I would like to, on behalf of everybody who's watching this and will be watching it back, and everybody that all of your work that you're doing to help this cohort of people to live full and active lives, on behalf of the whole rheumatology community, I'd like to say thank you, Dr. Siebert, for what you do and what all your colleagues are doing. And please keep up the good work, because it's just been fantastic. And I'm truly honoured to be able to speak to you this evening and bring all this information to you. And lots of really nice comments coming in to say thank you so much as well. Before we end tonight's Facebook Live, I've got to give a little plug for last week. We launched the SMILE RA, which is Self-Management Individualized Learning Environment in RA. There's 4 modules. It's absolutely free. Please go on our website and you can work through that. And we're going to be adding new modules to that. And so please have a look at the NRAS website for Smile RA. And that will help you to manage your disease and live full and active lives, which is what we're all about. And thank you to everybody out there who has already done the Do the 20 challenge to celebrate NRAS's 20th birthday. We're in the last few weeks now. The run up to our actual birthday is the 18th of October. And yes, I am going to do the 20 challenge. So watch your social media channels. I will be coming to a screen near you soon with a very, very silly challenge. So I hope you'll support me in that as well. But thank you for everybody that does support NRAS. As you know, we don't get any statutory funding. So all the things that we do to help support the whole rheumatology community, the academics, the scientists, the healthcare professionals, and of course patients, is all down to all your generous support. So I really appreciate that. I'd like to say thank you to my 2 colleagues who have been listening behind the scenes and feeding me questions. Thank you, Nadine and Debs. And again, once more, thank you so much, Stefan, for a really interesting and fascinating conversation. Thank you and good night, and stay well, everyone, and get that 3rd dose.